patients who were treated for Cushing's disease and identified a persistent increased mortality ranging from 3.8 to 5%. In a very recent 1 month ago publication by Clayton, who sort of did a meta-analysis, he identified that the standardized mortality ratio was around 1.5 times, not significantly different from the normal population in those deemed to have remission. I have identified some of the studies which did include Cushing syndrome as opposed to Cushing's disease, but generally the studies of Cushing syndrome had about 80% Cushing's disease, so the data would generally hold true in Cushing's disease. This is the data on Cushing's disease that has been followed up and compared to an expected population. Cushing's disease, where the etiology was proven after surgery, where this is adrenal Cushing, and this is Cushing's disease, where the etiology was not proven, couldn't identify the adenoma. It was much worse compared. The summary of this slide is basically Cushing's is associated with an increased mortality in patients with no concurrent malignancy. The increased mortality is mainly observed in the first year of disease, and the impaired quality of health in long-term survivors is not fully explained. Way back in 1998, I was privileged to be involved in the Auckland group, where we analyzed Cushing's disease as compared to a matched New Zealand population, and we found definitely a decreased mortality. In terms of morbidity, hypertension, pre-treatment and post-treatment, there was a significant difference, as was for diabetes, psychiatric comorbidity. Osteoporosis wasn't significant, but hypogonadism definitely. And major sepsis, even post-treatment, they do have major sepsis problems associated, particularly in Addisonian states. In a very recent, provocatively titled publication by Susan Webb, where 98 Cushing's patients, of whom 73 have Cushing's disease, were analyzed and compared at diagnosis, after cure, and compared to the controls. The trend is there's improvement of diabetes, but it doesn't quite approach the normal population. And you will see that hold true for dyslipidemia, hypertension, and central obesity too. What about osteoporosis? In terms of bone loss induced by glucocorticoids, it has been shown to be substantially reversed after steroid withdrawal. Two prospective studies have demonstrated a reaccumulation of bone density over the same period. The last part to emphasize is biochemistry should precede radiology, not only for cost reasons. It is also because if one rushes into radiology, one lands up with having in one's hand an incidentalloma in 10% of instances. And then one gets into a difficulty trying to interpret, is the incidentalloma the cause, or is that an association? So, the emphasis I want to lay is diagnosis involves a two-stage process. You confirm and then you establish the cause. To screen, we use tests of high sensitivity, and these tests are useful only in periods where there's hypercortisolism, and biochemistry should precede radiology. As far as diagnostic strategy is concerned, the Endocrine Society, in its recommendations, recommend 4 groups of individuals who should be screened: those who have unusual features for age, those with multiple and progressive features, children with decreased height and increased weight percentile, and patients with an adrenal incidentalloma compatible with the adenoma. All this after excluding drugs or exogenous causes. So you screen this group. After that, this is just to mention that Cushing's is a condition where it's more like accelerated aging. As we all age, We find individuals getting hypertension, diabetes, osteoporosis, central obesity, depression, dementia, proximal myopathy, bruising. And all these are features of Cushing's too. So it's like premature aging, and that's why unusual features for age is important to consider. The confirmation of Cushing's, besides a clinical assessment, you want to use 3 other utilities. That would be to demonstrate an increased filtered load of cortisol. That's usually done by 24-hour urine-free cortisol. You want to demonstrate a disrupted rhythm. Salivary cortisol is available in some places, but not in others. So plasma cortisol has been used. And lastly, commonly used is the attenuated negative feedback by means of low dose, high dose dexamethasone suppression testing. That will be in terms of confirmation. And then one comes to the root cause. On this slide is depicted from the left, the most common, to the least common on the right. One, of course, identifies this root cause by utilizing biochemistry, imaging, and image-guided sampling if necessary. Clinical assessment, the features of Cushing's are listed, but they're pretty common in the population. How does one identify those signs that may be useful in predicting Cushing's? Way back in 1982, Ross and Lynch wanted an index for a higher suspicion, and they came up with a discriminatory index. They identified the prevalence of features in each disease, each feature of a disease, and the prevalence of feature in patients suspected to have Cushing's but subsequently not. So they came up with this discriminatory index, and using the features of Cushing's, that value is depicted on the table there. What they have identified, which is useful clinically, is features which are reliable are reflective of protein catabolism, bruising, myopathy, hypertension. Features which are unreliable are very common in the population: acne, generalized obesity, impaired glucose tolerance. If you look at the Endocrine Society guidelines, like what I mentioned, they exclude exogenous glucocorticoid exposure, then they suggest one of the following tests: 2 urine-free cortisols, 1 overnight dexamethasone, or late-night salivary cortisol, and look at caveats for each test and use subsequently further evaluation. As far as urinary-free cortisol is concerned, it's useful to realize that false positives can occur with high fluid intake and where there is physiological or pathophysiological activation of the hypothalamus pituitary adrenal axis. In renal impairment, they may be falsely negative, cyclical Cushing's, and some patients with early mild Cushing's may have a urinary-free cortisol that's normal. And even among Cushing's disease, 1 in 4 may be normal in a lot of patients. What about the dexamethasone suppression test? It's a good screening test, it's an outpatient test, but even the dexamethasone suppression test may be suppressed to less than 55 nanomoles per liter, or less than 2 micrograms per liter, in patients with proven Cushing's disease, as in this study demonstrated by Findling. And the same group also identified in the same paper that these are patients who generally had a trend of a lower urinary free cortisol. So it's the mild Cushing's that may show suppression, and one may be misled into thinking they are not Cushing's. Salivary cortisol, this is just an illustration of the slide to say normal subjects, midnight salivary cortisol is low, as in obese subjects, as in pseudo-Cushing's. But in Cushing's, they tend to be high. But of course, as in all tests, there are overlaps. There's no test with 100% specificity or sensitivity. Where the tests are normal, they suggest Cushing's is unlikely, but where there are any abnormal results, they recommend then one should see an endocrinologist. Before that, one can consider, but it's not necessary. Then they suggest performing 1 or 2 other tests, which could be the DEX-CRH or the midnight serum cortisol. This is in substitution for the salivary cortisol. Just to illustrate the dexamethasone suppression test, when it first came about, Janowski and group proposed that it had 100% specificity and sensitivity, but this has since not proven to be true. Basically, after giving dexamethasone 0.5 milligrams 6 hourly for 2 days, followed by IV CRH, at 15 minutes, they found a clear distinction between those with Cushing's disease and those normal volunteers. The principle is that in Cushing's disease, they have receptors to CRH, and therefore they respond to CRH in terms of cortisol rise. So the algorithm follows: you suspect, screen, you confirm, then you identify the root cause. How does one go about identifying the root cause? I think clinical comes first. And in this slide, you will see a patient with a scar. If you pay close attention, you can see the nail fold pigmentation. That's the feet with edema, which is very common in patients with Cushing's. And you see the nail fold pigmentation. And if you look at the precursor of ACTH, pro-opiomelanocorticotrophin, one can understand why the associated pigmentation occurs. So that will be a clinical clue that might be helpful, but not always true, not 100% helpful. One, you can use ACTH to identify the group which is ACTH independent, that would suggest unilateral or bilateral adrenal disease, or ACTH dependent, which could be utopic, ectopic, or even rarely a CRH producing tumor. The ACTH is of course prone to a lot of problems. MRSA is more precise and sensitive than radioimmunoassay. The POMC is not detected by RIA. For ectopic ACTH, radioimmunoassay seems superior, and ACTH, one has to collect it under standard conditions because it's prone to degradation, and of course the problem of cyclical Cushing's and intermittent Cushing's are true. The CRH test has been proposed to distinguish between Cushing's disease compared to the rest, because non-pituitary tumors do not respond to CRH in the same way that the desmopressin test has been used to distinguish and subtype the Cushing's syndrome. Historically, the metharopone test was used, but metharopone is not routinely available and it's difficult. All of these tests have problems, and therefore it's a test of historical interest. The high-dose dexamethasone suppression test is still carried on, but it has some problems. Basically, the reliability in the distinction between pituitary versus ectopic ACTH is poor. While Cushing's disease generally shows suppression, some 20% don't show suppression. You need a test that is more than the pre-diagnosis probability. By looking at a female patient with Cushing's, you can sort of pre-test say most likely 80% this is pituitary, but you need a test which is more sensitive than that. So there are problems, and some have suggested that one could use a 90% cutoff of urinary suppression as compared to baseline for the diagnosis and distinction of Cushing's disease versus ectopic and other Cushing's syndrome. In terms of imaging, MRI, bilateral petrosa sinus, and if you suspect ectopic, CT thorax, abdomen, pelvis, and if you suspect adrenal, CT adrenals. Very rarely one may use adrenal venous sampling, but this is extremely rarely necessary. Now, this was a patient, a physician who had Cushing's. For 3 consecutive years, the MRI was reported normal. But he had Cushing's, and this was proven subsequently cured of his Cushing's disease. The point to drive at is 50% of patients will have a visible tumor on MRI. But if you want to be sure of the tumor, it must be distinct. One must look at the MRI images oneself. Of course, one correlates sagittal and coronal views. In a typical Cushing's, if it's more than 6 millimeter, most would be confident to go for surgery if all the tests point in the same direction. Otherwise, most will consider bilateral inferior petrosa sinus sampling. Pituitary incidentalomas are common, up to 10%. Dynamic sequences are more useful. The 3-Telsa MRI has been said to be better for smaller tumors. There is no difference in imaging features between functional and non-functional tumors. And of course, one looks for cavernous sinus oticus involvement. Petrosa sinus sampling has come into highlight more recently. And basically, you want to demonstrate a gradient between peripheral and central, and subsequently utilize it to lateralize adenoma, and which holds true in 70%. But using it to lateralize alone is not accurate, because besides failure to localize, one may fail to lateralize when there is incorrect catheter placement and the other reasons which are stated there. So lateralization not 100% useful as far as petrosa sinus sampling. After you have identified this, more or less summarizes the mechanism where ACTH is low, ACTH independent, ACTH high. You proceed to MRI, ACTH low, go on. If it's equivocal, a CRH test has been recommended, and then comes the imaging procedures. Macro and microadenoma, cortical macroadenomas occur for 20% in some series. ACTH seems to be more, maybe because of the size of the tumor. They are less responsive to suppression by high-dose dexamethasone, giving false interpretations. Patients with macroadenoma tend to be older, and visual fields impairment naturally may occur more in that group. As far as perioperative management, most centers give steroids preoperatively, but is this really necessary? A group from Cleveland studied patients who had an adenoma removed, and they identified some important things. The half-life of cortisol is 50 to 75 minutes, and the level of cortisol are usually detectable 12 to 14 hours after surgery. And they do not recommend routinely doing it for surgery, pre-surgery, but you monitor them. Where there's a deficiency, you go on to give cortisol, because this will help you identify the cure. Transsphenoidal surgery is a potential for curing it. Initial remission rate, 60 to 80%. Recurrence can occur, so a lifelong follow-up will be necessary. If there's persistent disease, some would go for resurgery, and patients will have hypocortisolemia if they're cured, and they may require steroids 6 to 18 months, and long-term follow-ups necessary. After surgery, 3 potential outcomes occur: complete remission, or some may take a little longer, some may have persistent. That's the definition of complete remission. Predictors, clear-cut ones are ticked in green, equivocal ones in orange. So it depends on the adenoma size, extension, post-op cortisol levels, intraoperative tumor identification, single pituitary surgeon. That's experience. If you fail with surgery, you have an option directed at the pituitary or at the adrenals, and that may be surgery, radiation, medical, or bilateral adrenalectomy. And bilateral adrenalectomy is efficient, negligible mortality, but associated with problems including lifelong steroid therapy, fear of Nelson syndrome. In this day, not everybody gives routine radiation. They tend to observe the MRI. Where there's a growth, they radiate. Medical treatment, there are many drugs used that affect the various pathways in the adrenal biosynthesis of cortisol. And pasireotide has come into the market recently, not fully available, but it has just come out as a publication in New England Journal of Medicine as a brief publication. The next speaker will talk more about this, but basically it treated patients, 76% achieved decreased cortisol. Radiation may be conventional. It's associated with success 50 to 60%, and it takes time to work. Or it may be stereotactic in 3 forms where the experience is very limited. Gamma life is not as great as it was thought to be. Quickly, first transsphenoidal surgery, patient cured, successful, well, married with 3 children, very well. This patient had a macroadenoma, transsphenoidal surgery, unsuccessful, ketoconazole tried, failed, then bilateral adrenectomy, still doing reasonably well. This is a patient who over years was not identified to have Cushing's despite changing appearance. Worse still, radiology showed osteopenia missed, and when she came, she had florid Cushing's, and it didn't identify the tumor easily, although we knew it was ACTH dependent. We went on to do petrosal sinus sampling, demonstrated a high gradient, and subsequently went for surgery. With disappointment, no cure. Patient, physician, neurosurgeon, all disappointed. What option? She was treated with ketoconazole, urine-free cortisols, responded extremely well. But that's not the end of the story. We still have to identify her tumor. And she's not going to be on persistent long-term ketoconazole. So Cushing's is like a maze. You start off deciding yes or no, exogenous or endogenous. After that, ACTH dependent or independent. And then you decide, is it ectopic or utopic? Even if you identify as utopic Cushing's, the big problem exists in your hands. So I've gone through morbidity, mortality, principles of investigations, the types, the order, the role for steroids, and the options in failed treatment. I share with you some important quotations. If you have never missed the diagnosis of ACTH-dependent Cushing's, and you have never been fooled attempting to establish a cause, you should refer your patient to someone who has. If you assume we know all about Cushing's, we just have not seen enough. If you confirm every case of Cushing's we have suspected, we're just not thinking of the condition enough. If we think we can cure every Cushing's we see, it means we're just overconfident. And lastly, where the tests are incongruent and you have male patients with Cushing's, consultations will only benefit the patient and all of us. Thank you very much.
Thank you very much, Professor Rajasoorya. What we'll do is to leave the questions right at the end, and